Plaque is visible years before a heart attack. Standard care often finds it after damage is already done. At 6:40 on a Tuesday morning, a 47-year-old commuter stops halfway up the station stairs, feels chest pressure, blames bad sleep, and keeps walking. But here is the hidden mechanism. While his arteries may already be changing in ways he cannot feel, that quiet miss now scales to 19.8 million deaths in 2022. Global cardiovascular disease rose from 271 million people in 1990 to 523 million in 2019, reached 612.06 million in 2021, and could cost more than $1.044 trillion a year by 2030. If his first clear symptom is a true heart attack, part of his heart muscle may already be dead, replaced by scar that cannot contract. The new tools are specific. AI models read coronary CT angiography and even routine chest X-rays for subtle signatures of plaque, inflammation, and anatomy. Systems like CardioKG connect imaging to biological databases, genes, and drug maps to surface targets older cardiology could not see. Separate teams are testing RNA drugs, somatic CRISPR edits, stem cell patches, and one startling regenerative switch, cyclin A2, or CCNA2. The core question is not whether heart disease can be detected earlier. The harder question is whether earlier detection, targeted drugs, gene correction, and tissue regeneration can form one real pipeline that changes outcomes before damage becomes permanent. Some preclinical studies now suggest the adult heart may not be as irreparable as medicine long assumed. If this kind of first principles medicine fascinates you, subscribe to CivilizationX. Now let's look at the mechanism. A heart attack is usually the end of a long failure, not a sudden event. Artery walls are injured by pressure, smoking, diabetes, and metabolic stress. Cholesterol-rich particles enter the wall. Immune cells follow, become foam cells, and build plaque. Some plaques grow slowly. Some become inflamed, fragile, and dangerous before they cause major blockage. That is why a person can pass a basic checkup and still carry real risk. Conventional scores compress this into age, cholesterol, blood pressure, and family history. Useful, but low-dimensional. Modern cardiology produces far richer signals: CT scans, X-rays, ECGs, lab panels, genomics, and longitudinal records. But here is the part that resets the story. AI on coronary CT angiography is moving beyond stenosis alone. It measures total plaque volume, low attenuation plaque, and high-risk morphology, because many heart attacks come from lesions that were not previously flow-limiting. Across studies, AI imaging systems report AUC values from 0.76 to 0.92, and some CCTA tools reached 99.7% accuracy for over 70% stenosis, and 94.8% for over 50% stenosis. But screening math is brutal. If 1 million people are scanned, true dangerous plaque prevalence is 1%, sensitivity is 90%, and specificity is 99%. But here's the problem. You detect about 9,000 true positives and create about 9,900 false positives. The value is not perfection. It is moving people like that commuter into deeper workup years earlier. Dr. Michael Liu put the near-term goal plainly: identify younger to middle-aged people with atherosclerosis and test AI-enhanced plaque analysis to decrease coronary plaque. Then, the biology widens. AI, omics, and systems biology are now mapping disease pathways once treated as too messy to drug directly. CardioKG links heart imaging with biological databases and has predicted genes and even existing drugs, including methotrexate for heart failure, as candidates worth testing. RNA therapeutics push on the same logic from another angle. They can influence almost any gene, and early trials suggest some may lower cholesterol more effectively than standard treatment while acting on deeper disease biology. CRISPR goes after faulty instructions themselves, especially in inherited cardiac disorders, by editing specific DNA sequences in somatic cells, not embryos. And then comes the shock. In preclinical work, reactivating the natural gene CCNA2 while reprogramming metabolism pushed adult human heart cells back into division. Thomas Braun said this doubled the number of heart muscle cells, and after infarction, heart function was almost completely restored. But if that's possible, what does it mean for adult human heart cells? Hina Chowdhury's group reported even middle-aged adult human heart cells could be coaxed back into making new functional cells. The old rule was simple. Adult heart muscle does not regenerate. That rule now has an asterisk. Stem cell patches add another route. Reprogrammed adult stem cells are grown into tissue, delivered minimally invasively, and in preclinical testing, they improved function, reduced scarring, and increased vascular growth. But the system hit a harder wall. Detection is not reversal. A model can score 0.92, yet still overload clinics with follow-up scans, if deployed blindly. Regeneration in pigs or human cells is not proof of safe human therapy. Gene editing still faces delivery limits, off-target risk, and long follow-up. Germline editing remains an ethical boundary, so the honest answer is layered. AI can expose invisible disease earlier. Targeted drugs and RNA therapies may reduce plaque-driving biology. CRISPR may help inherited disorders. Regeneration is the most powerful idea, but still the least proven in patients. The plausible path over the next decade is not one miracle treatment. It is a stack. AI triages risk from routine scans and records. Omics-guided drugs hit the right pathway. Somatic gene editing treats selected inherited cases. Regenerative patches or cell cycle control try to replace scar with working muscle. The near-term milestone already in motion is AI-enhanced plaque analysis inside clinical trials and hospital imaging workflows. The real bottleneck is scale, manufacturing, regulation, diverse datasets, and access outside elite centers. So return to that Tuesday commuter on the stairs. Today, his small warning might qualify him for deeper imaging, blood profiling, and a more precise map of whether his future depends on lifestyle, inherited risk, or damage already underway. His biology matters. But so does his postcode. Can scientists regenerate enough adult human heart muscle to replace scar without causing arrhythmias, tumors, or harmful off-target edits? Tell me what year you think that becomes routine care. Subscribe to CivilizationX. We are building a library of first principles documentaries about the engineering constraints behind humanity's future. The constraint is real. The data exists. Whether the systems built around it can act on it at scale, that is the next engineering problem.